What is your diagnosis?
Fibromas, neurofibromatosis.
So it's neurofibromatosis, multiple neurofibroma on her back, and in neurofibrosis we need regular eye examination. Okay, now I'm reading the explanation. Okay, so neurofibromatosis type 1 is an autosomal dominant neurocutaneous disorder. Autosomal dominant neurocutaneous disorder typically results from inherited mutation of NF1 tumor suppressor gene. Mm, NF1 tumor suppressor gene on chromosome number 17. Neurofibromatosis type 1 is inherited with complete penetrance and variable expressivity. Complete penetrance and variable expressivity. Rarely the mutation of NF1 gene occurs sporadically. The disorder presents with cutaneous neurofibroma, benign neoplasm derived from neural crest cell, calf eyelid spot, axillary or inguinal freckling, pigmented iris hematomas, leash nodule, optic glioma, and pheochromocytoma. Pheochromocytoma, according to the guideline from the American Academy of the Pediatrics, and patients with neurofibromatosis type 1 require annual examination. Patients with neurofibromatosis type 1 require annual multidisciplinary screening, including ophthalmic, neurologic, and dermatological examination, blood blood pressure monitoring, dermatological examination, blood pressure monitoring, and growth and bone health monitoring. Ophthalmological examination is useful for early detection. Ophthalmological examination is useful for early detection and treatment of OPG, which can tend to occur before age 6 years, which tend to occur before age 6 years. Treatment include surgical debulking of the tumors and management of seizures and neurological complication and genetic counseling. Okay, so we need to up to 6 years, like optic glioma can happen within 6 years. So we need two yearly examination of up to 6 years or lifelong.
No, they just said that they occur before the age of 6 years
Six.
old. Six
Yeah.
years old. That's why we start monitoring since the beginning.
So from birth, when we see that there is neurofibromatosis,
Mm-hmm.
then we start.
Mm-hmm. Mm-hmm.
Okay.
Next. A 7-year-old girl brought to the physician by her mom because she's concerned that her daughter has had 2 episodes of vaginal bleeding during the past 3 months. She also has had breast development during this time. Development has been appropriate for age. She's 48 percentile for height and 47 for weight and BMI. Breast development is sexual standard stage 2, and axillary and pubic hair is standard stage 3. Exam shows normal appearing external genitalia. Pelvic exam is not done. MRI of the pelvis shows a normal vagina and cervix. The uterus is 4 centimeters long and 7 times 6 left ovarian mass is seen. Which of the following is the most appropriate next step in diagnosis, in management? Sorry.
Okay. So puberty refers to the normal hormonal and physiologic changes as occur in these children. The common age range from the onset of the puberty in female age 9 to 12 years. Although this can vary markedly among the patients based on the factors such as body habitus and ethnicity. So precocious puberty refers to the onset of secondary sexual characteristics before age 8 years. Before age 8 years in female and 9 years in male, it can be idiopathic and or have a variety of the causes such as central nervous system lesion, ovarian or germ cell tumor, adrenal disorder, or genetic defect such as McCune-Albright syndrome. Precocious puberty can be further defined as central or peripheral. Central precocious puberty caused by an early activation of the hypothalamic pituitary gonadal axis, whereas peripheral precocious puberty is caused by excessive release of androgen. Ovarian tumors such as sex cord stromal tumor can present with precocious puberty in children, which is likely cause in this patient given MRI finding, as they may be malignant. The most appropriate next step in the management of this patient's condition is left oophorectomy to remove the ovarian mass. Okay,
Next, 3-year-old boy brought to the physician because of scaling lesion on the scalp for 7 days. The family has no pets. The daycare center that the child attends has a turtle. The other children at the daycare center are symptomatic. Examination of the scalp shows a thin plaque with alopecia and scaling. Which of the following is the most appropriate pharmacotherapy to prevent spread to the children in the daycare?
okay. Um, as there is scaling on the scalp, so it looks like tinea capitis, and this scalp is thin black. Okay, tinea capitis is a fungal infection of the scalp that is common in children. It presents as scaly patches with alopecia, patches of alopecia with black dots represent broken hairs and cervical lymphadenopathy. Common causal organism is the most common causal organism is Trichophyton tonsur, Trichophyton tonsurinus tonsurans. Although infection can also be caused by Trichophyton microsporum and Epidermophyton. A potassium hydroxide preparation of a skin scraping will show fungal hyphae or spore. It is treated with oral antifungals such as griseofulvin or terbinafine.
You read C and E.
Yes, topical hydrocortisone for the patient only is useful for atopic dermatitis. It is not for it is not useful for the treatment and may worsen tinea capitis. And topical selenium sulfide for the patient only is incorrect. Selenium sulfide is an antifungal drug that is topically a lotion or shampoo in the treatment of pityriasis versicolor, dandruff, or seborrheic dermatitis. It is not effective against tinea capitis. So how we like in the scalp tinea capitis along with this seborrheic dermatitis is common. Is the seborrheic dermatitis? Is yellow color? Is there anything like that?
Yeah, it says it's yellow color, yellow scales, and oily in the areas of oily body. Yeah.
And in here, just a scaling on the skull, thin
Here
black.
is not yellow.
Yes, here is not yellow. This is the only differentiating part.
Probably not. It's probably more things. Mm, 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 mm. There's probably more things. Mm, 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 mm. It says seborrheic dermatitis, red pruritic is itchy, greasy scales,
Yes.
red greasy scales. And you use antifungal. Okay, yeah. Oh, in babies, that's when it's yellow greasy scales in babies. Okay.
This is the baby. This patient is baby. So in here there is, if we find yellow greasy scalp, then it is seborrheic.
Yellow greasy scales. Uh-huh.
And
Yes, it,
for tinea capitis, like there is scaly patches with mild hair loss. Mm,
yeah, it's a scaly red patch with hair loss on scalp
scalp. There may
and
be black dot.
on lymphadenopathy. Uh-huh.
Okay. Okay.
Okay. Next. 5-year-old boy brought to the physician by parents as a new patient because they are concerned that he may have an immunodeficiency. The family recently moved to the area. The parents said their son's previous physician had been examining him for the condition. The patient has had six episodes of pneumonia, 10 episodes of sinusitis since birth. He underwent uncomplicated surgical drainage of the sinus at age 3 and 4. He had his first episode of otitis media at 2 months and underwent uncomplicated placement of tympanostomy tube at 7 months. Umbilical stop fell at the age of 2 weeks. Patients previously leukocyte, lymphocyte, and platelet serum immunoglobulin and CH50 concentration, and diphtheria, tetanus, pneumococcal, Haemophilus influenza titers are all fine. 6. Previous chest X-ray showed lower lobe consolidations in inconsistent locations. Subsequent X-ray show clearing of the infiltrates. Today, vital signs are normal. Exam shows no abnormality. This kind of the chest is shown. What is the diagnosis?
So what is your diagnosis?
Kind of looks like bronchiectasis here, but
Yes.
on the CT scan.
Yes, it
Oh,
is bronchiectasis. It may be cartagenar, isn't it?
yeah, kind of. Yeah.
Primary
Or,
ciliary. Sorry.
or it can be the leukocyte adhesion because of the thing that fell off to the umbilical stuff that fell off more than 2 weeks.
Umbilical, yes, before 30 days, yes. Leukocyte
Mhm.
adhesion, but leukocyte adhesion does not cause this typical bronchiectasis like tram track
Yeah, yeah,
classification. There
yeah.
is, and another thing like, okay, mm, okay, primary ciliary dyskinesia. Mm, So primary ciliary dyskinesia, also known as primary ciliary dyskinesia, also referred as immotile cilia syndrome. Immotile cilia syndrome is a rare congenital disorder characterized by defective cilia and inability to clear the mucus and debris from airways. There are numerous mutations. That can be. There are numerous mutations that can be seen that can cause the syndrome. That can cause the syndrome, which results in which results either in impaired ciliary function or absent cilia. Clinical manifestation vary. Clinical manifestation vary through though most patients with experience recurrent upper and lower respiratory infection. Other manifestation include chronic rhinosinusitis, otitis media, uh, infertility, notably approximately half of the patient with primary ciliary dyskinesia will have situs inversus. Carter-Jenner syndrome refers to the subset of the patient with primary ciliary dyskinesia who have clinical triad of situs inversus, chronic sinusitis, and bronchiectasis. Okay.
C.
Yes. In leukocyte adhesion defect, the leukocyte adhesion defect disorders are characterized by impaired attachment of the leukocyte to the vascular endothelium and recruitment and migration of the leukocyte to the site of migration of the leukocytes to the sites of extravascular inflammation or infection is reduced. Lab studies in patients with leukocyte adhesion deficiency will show increased absolute leukocyte count in the blood as the leukocytes are uh, unable to maintain their normal marginated position outside the bloodstream against the blood vessel.
Okay. Next. Physician who is covering for a colleague who is out of town receives a telephone call at the office from a dentist regarding whether antibiotic prophylaxis is needed for a scaling procedure for the colleague's patient. The patient is a 50-year-old woman with mitral valve prolapse diagnosed 15 years ago prior to her transferring to the colleague's care. She has never had endocarditis. Further review of the patient medical record indicates no documentation or echo. She also has hypertension, diabetes, and allergy to penicillin. Medications are lisinopril and metformin. Cardiac exam show from the patient as of his visit 6 months ago show normal pulse and no murmurs. Which of the following is the most appropriate next step in management of the colleague's patient?
Okay, so I advised the dentist to proceed with the procedure without antibiotic prophylaxis. Okay. Cardiology societies of US and Europe have guidelines recommending the use of antimicrobial prophylaxis during invasive dental procedure for the prevention of bacterial endocarditis in certain situations. Dental procedures that disrupt the mucosal lining. Dental procedures that disrupt the mucosal lining of the mouth are also known to cause transient bacteremia. However, the risk of subsequent invasive infective endocarditis is less established. The recommendation for antimicrobial prophylaxis is based on the expected risk from the patient's underlying endocardial condition and the degree of potential harm. If infective endocarditis does overlap These conditions vary. These conditions include the presence of prosthetic valve, a prior history of infective endocarditis, congenital heart disease, cardiac transplantation, and patients with valvulopathy. For an otherwise healthy patient with mitral valve prolapse, the physician should advise the dentist to proceed the procedure without antibiotic prophylaxis.
You read B and E. I mean, the
Which
first
one?
one. B and E. The
Ask the
first.
ask the dentist to postpone, then schedule outpatient echocardiography, or ask the dentist to postpone the procedure and then the schedule an examination in the office, and are not necessary for this patient who was seen in the past 6 months and has not developed any new cardiac symptoms. Prescribed clindamycin can prescribe clindamycin mm, to be taken an hour before the procedure and is not recommended for any patient undergoing dental procedure because the frequency of adverse event and limited poor proof of benefit. Can you summarize
Oh, which one? The
the whole explanation?
Oh, they're saying that she doesn't need prophylaxis because they only give prophylaxis to people with prosthetic valves. She doesn't have it, or people that had prior endocarditis. And on the question, he says she never had endocarditis before. And then if they have a congenital heart disease, usually I read on thing on the other books that it says congenital heart disease with
Symptom.
that with symptoms with cyanotic congenital heart disease.
So this MVP will not gonna consideration.
It's not cyanotic. The
Yes.
cyanotic, yeah, yeah, and she will have symptoms, but she never had symptoms. He says that she never had symptoms. And then cardiac transplant with valvulopathy, so with unrepaired valve.
Okay.
Yeah, but this one, she's not. She doesn't have a cyanotic one. She doesn't have symptoms, so we don't need to give prophylaxis.
Okay. And previously we have read for dental procedure, like we can
Mm-hmm.
give amoxicillin
Mm-hmm.
2 hour before the procedure.
It was two or one. I don't remember. Was it two
I
or one?
forgot, but
I
it
forgot.
is some hour before the procedure.
Yeah, it's like 1 hour or two. I don't know, but usually it will be clear. Like I feel like on the thing is pretty clear. I think it's 1 hour.
And
Usually it's like
if the patient is like penicillin allergic, we can use azithromycin. That's
as it
the
um, yeah.
okay.
Yeah. Usually they will give you like an hour before or 2 days before or 1 week before, and it's like pretty obvious. You will know it's like an hour before, not 2 days before. Yeah. Mm, okay. Next. 52 women with ALS has been receiving mechanical ventilation in the hospital for 4 weeks. She's taking no medication. Attempts at discontinuing the mechanical ventilation have been unsuccessful. Her parents visit her often and participate in her healthcare decisions. The physician tells her and her parents that she could require mechanical ventilation for more years and recommends transfer to a facility for ventilator dependent patients. Although the parents approve of the recommendation, the patient refuses placement and asks to have mechanical ventilation and everything stopped. She says, I would rather die now than spend the rest of my life in one of those places. Which of the following is the most appropriate next step?
Okay, assess the patient's mental capacity to make her own decision. Okay, to meet the criteria for decisional capacity, to meet the criteria for decisional capacity, patient must experience the patient must, sorry, the patient must express a consistent choice. A patient must express a consistent choice and demonstrate an understanding of the risks and benefits of the choice, an appreciation of the significance. Demonstrate an appreciation of the significance of the choice for their personal circumstances, and illustrate an inability to reason through the options. Capacity assessment are based on discussion with the patient in order to assess these four factors: understanding, appreciation, reasoning, and choice. Understanding, appreciation, reasoning, and choice, and can be conducted by the physician. Capacity is not a global assessment, but rather pertains to specific decision. Therefore, the assessment should be based on individual patient, their condition at that time, and the particular medical decision being made. The assessment must be performed rigorously in settings where the consequences of the decision are partially serious, as in this case, this patient with amyotrophic lateral sclerosis has a poor long-term prognosis and is facing end of life end of life decision making. Some patients may have a value, quality of life, or comfort rather than a prolongation of the life, and patients have a right to express these values in their decision making. This patient is alert and appears to have decisional capacity. A further assessment of her capacity should be conducted to explore her reasoning and to exclude other factors such as depression that may limit her capacity. Okay.
Okay. 62 men comes to the physician because of a lesion in his right temple for 3 months. Oh, it's not working. He works as a farmer. Exam shows 1.5 centimeter ulcerated lesion over the right temple area. The lesion has raised margin and waxy border. If left untreated, which of the following is the most likely sequela of the lesion?
Okay. Basal cell carcinoma. Basal cell carcinoma is the most common form of skin cancer and is derived from the basal cells of the epidermis. The primary risk factor for developing basal cell carcinoma is the ultraviolet light exposure through though age, hair, skin, and family history are contributed. Basal cell carcinoma are typically present as pink pearly papule of nodule with rolled borders central ulceration, commonly on sun exposed area of the head and neck. Subtypes of basal cell carcinoma include those that are less invasive, such as superficial or nodular, and those that are more invasive, such as infiltrative and morphiform. In all subtypes, the risk for metastasis is low, and although the tumors can invade locally and can cause significant tissue damage, biopsy may be performed with a variety of techniques like excisional, shave, punch. Treatment for basal cell carcinoma involves surgical removal either via excision or Mohs microscopy surgery. In the case of incomplete excision, re-excision with negative biopsy margins indicated the reduce the risk from local spread. Okay,
I thought basal cell carcinoma was
sorry,
fairly wide,
Parley,
fairly pink.
it is there in the first in the UL there are some questions,
Mhm. Okay, so it's fairly
and
papu. I thought it was this one.
and there is inside there is telangiectasia.
Telangiectasia, but here they're saying something
Sorry,
more like this, I guess.
yes, it is not actually look like that. In
Okay,
the left one, this one, yes,
this
this
is
is the actual picture. Yes, click it, click that picture. Look deep inside. Look,
yeah,
yes,
the
there is
telangiectasia.
telangiectasia, and in the first state, the question looks like this.
Yeah, but here they describe it more as ulcer with raised border, like something like this, like ulcer with raised borders. It's not like a papule, you see. Like the
Oh,
way they describe it here, it sounded more like squamous cell carcinoma kind of.
yes.
Yeah.
Okay, I'm coming. 5 minutes.
Okay.
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 Yes.
Okay. 57 man comes to the ED because of a 6 hour history of fatigue and mild shortness of breath. Okay. He has type 2 diabetes, hypertension, anuric renal failure, recurring hemodialysis. He reports having missed his regular schedule. Dialysis session 2 days ago, current medication and enalapril, amlodipine, insulin, calcitriol, calcium supplement. Temperature is fine, pulse is high, respiration high, BP high. Exam shows nodular venous distension, crackles are heard at both lung bases. Heart sounds normal. Serum study shows potassium, I guess, high, urea high, and creatinine super high. ECG shows sinus tachycardia with widening of PR and QRS intervals and peak T waves. IV administration of which of the following is the most appropriate next step?
Okay. Potassium is very high, and there is tall peak T wave, so it is hyperkalemia. So calcium chloride is the answer. Okay. This patient presentation is consistent with hyperkalemia in the setting of end-stage renal disease with persistent cardiac membrane irritability as evidenced by ECG finding consistent with hyperkalemia. The patient requires immediate intervention to reduce the risk of fetal arrhythmia. ECG evidence of hyperkalemia includes flattening of P-wave, lengthening of PR interval, flattening of P-wave, lengthening of PR interval, widening of the QRS complex, and the presence of tall peaked T-wave. Acute management in order of priority involves stabilization of the myocardium with calcium gluconate or calcium chloride, shifting potassium into the intracellular component using insulin and dextrose sodium bicarbonate beta 2 agonist, and removal of the potassium from the body using diuretics and oral potassium binders hemodialysis. After the patient is stabilized, evaluation should be directed to identify the cause of hyperkalemia. In this patient, the most likely explanation of hyperkalemia is missing dialysis with underlying end-stage kidney disease. Next step include Lab studies, urgent dialysis, urgent hemodialysis, and administration for further management.
Okay, next. 13 boy brought to the physician because of intermittent pain in his right thigh during the past 6 weeks. The symptoms are exacerbated during running, and his mother reported that he limps 30 minutes after running. He has no history of serious illness, takes no medication, no recent trauma to either leg. He has practiced with school football team 3 times weekly for the past 2 months. He is 75 percentile on height and his fat. Exam shows a normal gait. There is no tenderness of the right hip or thigh. Internal rotation of the right hip is difficult, especially when the knee is flexed. Genital and pubic hair development are done at stage 3. X-ray of the hip is shown. Which of the following is the treatment?
What is your
Which one?
diagnosis? Just looking at the picture.
Wait, which one is the right hip that she has, or is this one that she has an issue?
I
Uh,
think the left one. I'm on
wait,
my.
or is it this one or this one?
I think that isn't it
This
left
one.
one?
It says
But
right.
according to the description, yes, internal rotation of the right hip is difficult when the knee is fully flexed.
So according to the thing, is this one right? The right, but it
Yes,
looks like this one has a
yes.
problem. Okay.
Isn't it
Like
look like slip capital femoral
yeah,
epiphysis?
yeah,
But look at
yeah,
the left one. It is more slip than the right one.
yeah. Yes, yes,
Isn't it true? I
yes,
feel like the left one
yes,
is more
yes.
slipped than the right one. Left one looks
Mm,
like normal.
mm-hmm. Yes.
Okay, I don't know. Maybe
Mm,
they changed the picture.
mm. Okay.
Okay, it's scaphe, like slip capital femoral epiphysis. Slip capital femoral epiphysis in children occurs in children. It occurs in children. Mm, it occurs in children between the age 10 to 15 years who are overweight. Scaphe is a displacement of femoral epiphysis relative to the femoral neck. Displacement of femoral epiphysis relative to the femoral neck. Secondary to the anterior-posterior movement of the metaphysis, it is a Salter-Harris type of fracture. It is a Salter-Harris type 1 fracture of the growth plate. Scaphe typically presents with a painful limp if severe and may result in restrictive range of motion of the hip joint, limited abduction and internal rotation of the hip, limited abduction and internal rotation of the hip, and inability to bear weight. If untreated, complications include avascular necrosis of the femoral head and limited range of motion and gait impairment and premature osteoarthritis. To prevent this complication, treatment requires surgical stabilization of the femoral head. Okay.
Okay. 87 woman with type 2 diabetes comes to the physician for evaluation of non-healing foot ulcer that has increasingly worse tissue necrosis and erythema. She has a 2 year history of mild to moderate dementia, Alzheimer type, with no recent changes in cognitive status. The patient lives alone with help of various neighbors. Her only family is out of town sister with whom she last spoke 1 year ago. Physical exam shows 2 centimeter ulcer that exposes head of the first metatarsal. There is 1 centimeter centimeter necrosis and 2 centimeter erythema around the edge of the border of the ulcer. Mental status exam. Patient is alert and oriented to person and place, but thinks she's in 1999. She recalls one of three objects or five after 5 minutes. Where am I? Below the knee amputation is recommended. The risks and benefits of the operation are discussed with the patient. She understands and repeats the discussion, attempts to contact her sister and unsuccessful. Which of the following is the most appropriate next step?
Okay. Proceed with the amputation. Mm, to meet the criteria for decisional capacity, patient must express consistent choice. Patient must express consistent choice, demonstrate an underlying demonstrate an understanding of the risk and the benefits of the choice, demonstrate an appreciation of the significance of the choice for their personal circumstances, and in illustrates an ability to reason through the options. Although she displays evidence of mild to moderate dementia, these patients appear to meet the criteria of decisional capacity. Capacity assessment should be based on the capacity assessment should be based on the individual ability and the particular medical decision being made. While patients with the dementia may have impairment of their cognitive abilities, it should not be assumed that such patients lack capacity, as many are sit available to appreciate risk, conduct reasoning, and express choice. Okay.
Next. 47 woman comes to the physician because of a 2-month history of substernal chest tightness and shortness of breath associated with exercise and relief by rest. She previously walked 2 miles daily, but now she's limited to walking one half block because of chest pain, dyspnea, and lightheadedness. Okay. She has never smoked and drinks 1 to 2 beers daily. Temperature is fine, pulse fine, respiration fine, blood pressure fine. JVP is 8 centimeters. I guess fine. I'm not sure. Crackles are heard at both lung bases. The point of maximal impulse is increased but not displaced, and S1 is normal, but S2 is decreased. There is a grade 3 out of 6 systolic murmur at the cardiac base. Serum studies show total cholesterol. I believe that's high. HDL 95. Let me double check. Oh, cholesterol, yeah, is high. HDL, where am I? Is high, and
Right.
LDL is normal. And then which of the following is the most likely cause of the patient heart failure? Okay, I guess JVP was high.
Normal JVP is 3 to 5, isn't it?
I thought it was okay, 3 to
Uh,
5.
you are thinking CVP.
CV, oh my God.
There is another thing like CVP, central venous pressure. In CVP, we add 5 for the right atrial pressure, which was fixed. Don't you remember that picture?
Mm-hmm.
A lying man with measurement of CVP and
So
JVP.
JVP is 3 to 5. Okay.
Maybe.
Oh,
I need to find that question, then I can assure you. I don't know. Okay. Mm. So, what is your diagnosis? Just
okay.
reading this stem, I haven't found the
Like
diagnosis.
heart failure or something, right? I mean, she has. I mean,
What?
I don't know if it's like some kind of.
Like crackles are hard on the both lung base.
Uh-huh.
That's why left heart failure. That's you are talking
Mm-hmm.
about. and
Mm-hmm.
JBP is raised. Okay, but
Mm-hmm.
the murmur does not indicate anything as far I.
Yeah, cardiac based systolic murmur. S2 has a problem, so it's either pulmonic or aortic because it's S2 that has the problem. Um,
Yes.
yeah, that's all. I don't see anything else there.
Okay. Now, so this patient harsh systolic murmur decreases to harsh systolic murmur decrease S2 sound suggests aortic stenosis is the cause of patient symptoms. Aortic stenosis, usually this murmur located in the aortic area, isn't it? But they did
Mm-hmm.
not tell about the area.
There.
Okay. Many people will develop some degree of valve stenosis in their lifetime as a result of chronic inflammation with resultant calcification and fibrosis over time, with the aortic valve most commonly affected. Early onset aortic stenosis 40 to 60 years, as in this patient with the setting of congenital bicuspid aortic valve, congenital bicuspid aortic valve, and or chronic rheumatic heart disease and or chronic rheumatic heart disease. Patients may complain fatigue, shortness of breath, cough, diminished exercise tolerance, chest pain, or syncope with exercise. Examination findings include crescendo, decrescendo, systolic, murmur, best heart at the right upper sternal border. Crescendo, decrescendo, systolic, murmur, best heart at the right upper sternal border. Pulsus parvus and tardus. Pulsus parvus and tardus, weak and delayed, may be noted on examination of the peripheral pulses. A diminished S2 sound results from weakened closing of the valve. Severe aortic stenosis can lead to left ventricular hypertrophy and heart failure over time. Okay.
You read B.
Yes, amyloidosis, in which patient, proteins deposit in tissue and can cause organ dysfunction, can cause restrictive cardiomyopathy. Amyloidosis is commonly associated with plasma cell dyscrasia such as multiple myeloma and chronic inflammatory conditions such as RA, SLE, inflammatory bowel disease. It is uncommon compared with aortic stenosis, as is likely with this patient.
And E. E.
Atrial fibrillation with rapid ventricular response, presence with episodic tachycardia, heart palpitation, shortness of breath, dizziness, anxiety. Patients will have irregularly patients with um, patients with have an irregular pulse, and typically heart rates are greater than 100 beats per minute. Okay.
Okay. 30-year-old man who is a U.S. Army is brought to the ED of a military hospital 40 minutes after being hit by a motor vehicle traveling 25 miles per hour while he was walking. On arrival, he's unconscious. Temperature is fine, pulse is high, respiration high, BP low, pulse oximetry, oxygen saturation is 90. On exam, the abdomen is rigid. He's resuscitated with 8 units of packed red blood cells, 6 units of fresh force and plasma, and 2 units of platelet. Emergency laparotomy shows transection of the small bowel proximal to the second. Lab studies done 45 minutes after arriving in the surgical ICU shows an active partial thromboplastin time of 42
I-
MPT,
Isn't it raised?
I think so.
It may be up to 40 as far I remember.
What am I?
25 to 40.
Thromboplastin time. Yeah, it's thromboplastin time is raised and PT both are raised and INR is raised. Which of the following is the cause of the coagulation abnormalities in
So
this
what is your
study?
diagnosis if PTTINR is raised?
DIC.
Okay, it's a DIC. Disseminated intravascular coagulation is a systemic disorder characterized by widespread activation of the clotting cascade, mm, resulting in thrombocytopenia, and the bleeding uh, complication caused by consumption of the platelet and clotting factors. Cause of DIC are many, including trauma, sepsis, malignancy, pancreatitis, and exposure to toxin. Regardless of underlying cause of clinical effects include stigmata of bleeding, petechiae, purpura, oozing at surgical and venipuncture site, clinical evidence of bleeding, and lab abnormality reflecting DIC of the clotting cascade, increase APTT, thromboplastin time, and INR, the consumption of the platelet, and thereby additional lab abnormality, increased D dimer caused by the presence of fibrin split product and decreased fibrinogen concentration, along with increased biomarker of detectable free hemoglobin, decreased heptoglobin, and increased LDH. Intravascular fibrin stance and microthrombi cause shearing of the erythrocyte, leading to microangiopathic hemolytic anemia. Treatment includes correcting the underlying cause and resulting coagulopathy and thrombocytopenia. Okay.
You read D.
Hyperfibrinogenemia is a rare bleeding disorder with a spectrum of clinical severity. Patients who are
Wait,
most
where are you reading?
sorry, I am reading C.
Oh, D. D as in
Oh,
dog.
sorry. Hyperfibrinogenemia promotes thrombosis by enhancing fibrin formation and stability. It leads to increased coagulation. DIC leads to decreased fibrin concentration, whereas hyperfibrinogenemia presents with increased fibrinogen identified unless inadvertently identified in the setting of traumatic injury. DIC is more likely to cause the temporal correlation with trauma and intra-abdominal injury and consistent with the lab studies. Okay.
Next. 25 women gravid at one para one comes to office because of 3-month history of chronic moderate perianal pain and bleeding that began 3 days after she gave birth via C-section. Before the onset of symptoms, she had constipation associated with use of post-delivery oxycodone. The constipation resolved after she discontinued the medication, but her bowel movement have been painful and she has noticed blood in the toilet tissue. On 1 week ago, the patient obstetrician prescribed topical cortisone, hydrocortisone, and diltiazem, which provided temporary relief but do not resolve her symptoms. The patient medical history is otherwise fine. She doesn't take medication. Family history is fine. Vital signs fine. Exam of the anus shows a deep wound in the posterior midline with exposure of the internal sphincter muscle and associated skin tag. Which of the following is the most appropriate next step in management?
Okay, it's surgical repair. Anal fissure commonly presents with rectal pain, particularly with defecation and bleeding caused by a tear in the anal fissure. Most commonly at posterior midline. This tear in the mucosa may expose the internal anal sphincter and may be associated with local skin tag. Patients can offer pain can occur from irritation of the tear itself and spasm of the internal sphincter, the latter of which can cause ischemia and prevent healing. Causes of primary anal fissure include constipation, vaginal delivery, although secondary pertussis are initial manage sorry Initial management of the anal fissure includes prevention and treatment of the constipation, topical analgesic, topical vasodilator. However, these methods are typically ineffective for chronic anal fissure, which are present for longer than 8 weeks. Chronic anal fissure are those that is unresponsive to conservative management and should go undergo surgical repair. Okay.
You read A, yeah, A, B,
B.
A and B.
Biopsy of the wound is not necessary and may exacerbate patient's pain, and she has the classic symptoms of she has the classic signs and symptoms of anal fissure, with the fissure being evident on physical examination. And as soon as her symptoms have been responded to the conservative medical management, he should undergo surgical repair. And colonoscopy is used to evaluate the rectum and the colon. The superiorly, it is commonly used for cancer screening, not inflammatory bowel disease. These patient's symptoms are related to external anal injury. Anal fissures are not frequently related to the internal disorders, the presence of other symptoms. So colonoscopy is recommended. Colonoscopy is necessary. Okay.
Okay. 42 men brought to the ED by paramedics 1 hour after his girlfriend found him confused and agitated in his home. Okay. The girlfriend says that when she spoke with him on the phone last night, she noted no problem, but she became worried when he did not answer the phone 3 hours ago. He has 3-year history of chronic back pain for which he takes oxycodone. He also has MDD and seasonal allergies treated with diphenhydramine and citalopram, respectively. Oh, wait. On arrival, he's confused, screaming loudly, and actively pulling against wrist restraints. Temperature is high, pulse is high, respiration high, BP high, physical exam shows diaphoresis and tremulousness, whatever. The pupils are dilated. Which of the following is the cause of the patient's confusion?
So what is your diagnosis?
Jeez, I don't know. I was gonna say opioid withdrawal, but I guess it's not that.
Yes. Okay. I'm reading the explanation. So cocaine blocks the presynaptic reuptake of dopamine, serotonin, norepinephrine. Cocaine blocks the presynaptic reuptake of dopamine, norepinephrine, and serotonin, which increases the contractility of these symptoms, which increases the contractility of these substance that in the synaptic cleft substance in the synaptic cleft. Cocaine is an addictive recreational drug that typically causes euphoria, restlessness, and increased sympathetic tone, tachycardia, hypertension, pupillary dilatation, and increased sympathetic dopamine leads to addiction, and severe cases, hallucination and paranoia. Increased synaptic serotonin leads to euphoria, while increased synaptic norepinephrine can cause tachycardia and hypertension through activation of the sympathetic adrenal receptor, leading to increased cardiac chronotopy and peripheral vasoconstriction. The further, cocaine acts as a local anesthetic by the decreasing sodium channel permeability, uh, thereby slowing the blocking of pain and signal conduction.
Okay, next. 21 woman gravida Tupara 36-week gestation admitted to the hospital in labor. She received no prenatal care. She has no history of operative procedure. She reports that she occasionally used cocaine before she knew she was pregnant, but has abstained from illicit drug use for the past 8 months. On admission, the cervix is 5 centimeters dilated. 100% effaced vertex at the zero station. There is moderate amount of blood-tinged mucus. The membranes are artificially ruptured, yielding clear fluid. Blood group is A, Rh negative. A serum anti-D antibody titer is positive. During the next 30 minutes, fetal heart monitoring shows regular sinusoidal waveform. Which of the following is the cause of the patient? The cause of the fetal heart pattern.
Okay, so Rh negative mothers are at high risk of developing anti-Rh antibodies referred to as Rh isoimmunization if exposed to blood from Rh positive fetus. While the commonly occurs at delivery, it can also occur prior to delivery with a vaginal bleeding and procedures such as amniocentesis. If Rh negative antigens from the fetal circulation enter the maternal circulation, it is possible that the mother's immune system will form antibody against Rh antigen. This can result in hemolytic anemia of the fetus, erythroblastosis fetalis, especially with subsequent pregnancy, as the mother's antibody can cross the placenta, cause hemolysis of the fetal RBC. Rh immune globulin ROGAM acts by inhibiting Rh positive and that enter the maternal circulation. That enter the maternal circulation, preventing the immune system from developing antibodies. Rh antigen. It is commonly given to Rh negative mother at 28 weeks of gestation, and the sinusoidal pattern of the heart rate monitoring is indicative of anemia of fetus, likely secondary to hemolysis in the setting of Rh isoimmunization. Okay,
Can you read A?
yes. Abruptio placentae is a premature separation of the placenta from the uterus. It commonly presents with vaginal cancer, severe uterine pain, and tetanic concentration, typically in the third trimester, while cocaine toxicity is a risk, while cocaine toxicity is a risk factor for placental abruption. This patient has not used cocaine in 8 months. Given her blood and lack of prenatal care, Rh isoimmunization is likely cause of sinusoidal pattern or fetal heart rate monitoring.
Next. 22 college student comes to the physician because of a 3-year history of falling asleep during her classes. She worries that she will not be able to continue with her education because of this. She says that she always has had difficulty staying awake during class. Even in high school, she also occasionally has trouble staying awake during movies. She says she has no problem getting to sleep or waking up. She goes to bed between midnight and 1 a.m. and gets up at 8. She has tried sleeping for longer durations, even up to 8.5 hours, but she still has been unable to stay awake during the day. She has greatest difficulty staying awake during her classes after lunch. She thinks that she sleeps very soundly and moves little during her sleep because her bed sheets are neat when she awakens in the morning. She does not remember having dreams. She reports that no one has ever told her that she's no, she is BMI is fine. Physical exam fine. On mental status exam, she has concern, mood, and reactive affect. Which of the following is the most appropriate next step in diagnosis?
Okay. Mhm. Okay, it is multiple sleep latency test. Narcolepsy is the most common. Narcolepsy is most common diagnosis as the patient has daytime somnolence despite restorative sleep and no other features, pathognomonic or other REM sleep disorder. The pathogenesis of narcolepsy involves the loss of orexin A and orexin B, which are neurotransmitters found primarily in the hypothalamus that promote wakefulness and inhibit the REM sleep. Loss of neurons, loss of this neurotransmitter permits abnormal transition from wakefulness to REM sleep. They may experience Patient may experience hallucinations, cataplexy, sleep paralysis. The diagnosis can be made in patients with daytime somnolence and cataplexy, or cases or in cases where cataplexy is not present. With multiple sleep latency, test shows a shorter time from wakefulness to the initiation of the REM. Occasionally, patients undergo lumbar puncture to directly measure the level of orexin in the cerebral CSF. Okay.
You read A, B,
Minnesota multiphasic personality inventory choice A is uh, used to evaluate psychotherapy. It may be considered that there is concern for factitious or somatization disorder, workup for organic sleep disorder should be performed first. And which one?
B, B as in boy.
Overnight pulse oximetry is used in the initial evaluation of sleep apnea. Obstructive sleep apnea is commonly present with daytime or obesity, pharyngeal muscle weakness or rupture, pharyngeal muscle weakness or upper airway deformities, and often presents with life, snoring and lifetime apneic episodes. Both obstructive and central sleep apnea present with daytime somnolence. Multiple sleep latency tests will evaluate for disorder as well as this patient. Okay.
38 woman comes to office because of a 6-month history of progressive fatigue and muscle weakness. During this time, she has not been able to concentrate at work and has noticed her voice has become hoarse. During the past 3 months, she has had a 12-pound weight gain despite limiting her food intake. She has bipolar disorder, type 2 diabetes, and hypercholesterolemia. Medication metformin, lisinopril, lithium, pravastatin. Doesn't smoke, drink alcohol, or use illicit drug. Her temperature is fine, pulse is pretty low. Respiration fine, BP that's fine, high. Exam shows cold skin and coarse hair over the scalp. There is a firm, non-tender, symmetrically enlarged thyroid gland. The deep tender reflexes are 1 plus. Her serum TSH concentration is 25, which I don't remember what it. Results of serum electrolyte concentration and renal function tests are normal. Antithyroid peroxidase antibody testing is negative. Which of the following is the cause of these findings? Let me see. TSH is thyroid stimulating is
TSH is
high.
high.
Yeah.
Hmm. So it's medication adverse effect. Lithium is a mood stabilizing medication used to treat and acute mania and as maintenance treatment in bipolar disorder at the therapeutic doses. Lithium can cause variety of the adverse if effect include tremor, nystagmus, nephrogenic diabetes insipidus, and or thought dysfunction. Lithium is lithium induced Lithium induced diuretic functioning occurs in as many as 50% of the being treated with lithium and 1 to 2% of the beginning treatment. 1 to 2% or year of the beginning treatment. The most common manifestation is usually lithium induced um, uh, lithium in uh, lithium induced thyroid dysfunction and hypothyroidism goiter. Current goiter. Although hyperthyroidism and autoimmune thyroiditis may help to occur, the goiter that occurs in the lithium induced thyroid dysfunction is usually diffuse and non-tender. Patients become lithium treatment should undergo baseline thyroid function tests or evaluation. Treatment mm, treatment does not differ from thyroid disorder or other causes. It is not necessary to discontinue lithium treatment in the setting of thyroid dysfunction.
Can you read A, B?
Yes, autoimmune thyroiditis, also known as chronic lymphocytic thyroiditis, it is the most common form of thyroiditis.